think of respiration as gas exchange. So we're going to talk about how we're going to exchange gas between our systemic circulation and our tissues cells. So basically, like it says at the top of the screen there, we're going to move oxygen from the blood into the tissues. And then conversely, we're going to move carbon dioxide out of the tissues and into the blood. So again, I'm going to assume that you've watched those other videos here because this talks about that partial pressure. And again, going back, let's simplify. Remember our pressure gradients. Okay, gas is going to move from an area of high pressure to low pressure. That's not changing whatsoever. And so that's what we're going to see here. Okay, so let's take a peek at what I have up on the screen here, just so you guys kind of can track everything. We've got the partial pressure of oxygen in our cells is 40 millimeters of mercury. And the partial pressure of oxygen in the capillaries is 95 millimeters of mercury. So just going with what we know about pressure gradients, where does oxygen want to go? Where do you think? Yeah, it's going to go into the cells, right? Because you have the high pressure of oxygen in your systemic circulation, and then you have a lower pressure in the cells. So 95 millimeters of mercury in your blood, 40 in the cells. That's good, right? That's what we want. We're going to facilitate that diffusion of oxygen. All right, pretty simple concept. So I know you're all going to do well on that. And so, of course, just like with anything, just like with what you learned with diffusion way back when you first learned about it, it's going to continue until equilibrium is reached. And that's how it works. We're going to deplete the blood's partial pressure of oxygen until it is 40 millimeters of mercury, until it is equal, okay, to the tissue cells' partial pressure of oxygen. All right, so this is good. Right? This means that we're able to, because the nice thing about the partial pressure of oxygen is this word right here. It stays fairly constant, which is nice. So we can get the rate of exchange is going to be fairly the same. All right, obviously that changes during certain metabolic activities, for example, like exercising, okay, running a marathon or doing CrossFit or whatever type of strenuous exercise that one does. But keep in mind, as we're all sitting here, right, this rate of diffusion, right, is pretty constant while we're just chilling out and learning, okay? So that's not too bad. Internal respiration, not too bad. Now let's switch over to carbon dioxide. So if you look up on the screen there, I've even included a picture up here. You can see, right, on the right hand of that picture, you'll see that oxygen has that 95 millimeters of mercury in the blood, and it's got 40 millimeters of mercury in your tissues. So it's going to follow the red arrow. It's going to move from the blood into the tissues. All right, now we're going to go with carbon dioxide. Think about it. These tissues are undergoing metabolic processes, whatever. For example, maybe it's going to be making ATP. One of the byproducts of making ATP is carbon dioxide, which we would have learned if we were going to cover, right, chapter 2, 3, and 27, but we're not going to be doing that this semester. So you'll notice that the partial pressure of carbon dioxide in the tissue is 45 millimeters of mercury. See what it is here in your bloodstream, okay? Oops, sorry, over here, 40 millimeters of mercury. So where does carbon dioxide want to go? Follow the blue arrow. Carbon dioxide wants to leave the tissues and go into your blood until it reaches equilibrium. So again, relatively, I'm not going to say simple, but relatively easy to understand. If you made it this far in the course, you should understand these concepts here. So this partial pressure is going to drive that process of carbon dioxide leaving your cells, all right, and then entering into your capillaries. And it's going to do so until we reach equilibrium, okay, until the partial pressure of carbon dioxide here in the tissue, which is 45 millimeters of mercury, is going to equal the partial pressure of carbon dioxide in your systemic capillaries. Cool, not too bad. Right, again, it's all pressure gradients, high to low, high to low. Right, just know where it's higher, and it just makes sense because what do we need oxygen for? Aerobic cellular respiration. You want to get it from your blood into your tissues so the mitochondria can utilize that. All right, so this is just showing you basically what I was just telling you. So oxygen into the tissues, carbon dioxide out of the tissues for our gas exchange there, driven by the partial pressure gradient there. Okay, it is when we get into the beginning part, like at the arterial end of the capillary bed, all right, our partial pressure of oxygen is around 100 millimeters of mercury, it could be around 95, it varies. But point being is it's higher in the blood, lower in the tissues. So oxygen favors going into the tissues. Vice versa here with carbon dioxide. Carbon dioxide, the partial pressure in the tissues is 45 millimeters of mercury. Okay? When it gets into the middle to the end, to the venial end of the capillary bed, it's around 40 millimeters of mercury. Therefore, carbon dioxide favors leaving the tissues and going into your blood. Because we're going to transport that carbon dioxide where? Where are we taking it to? The lungs. Yeah, we're going to get rid of it. We're going to blow it off. Okay? We're going to just exhale it out. And so that's what these kind of loops are showing you. All right, we have our pulmonary gas exchange. This is what's going on up here in the lungs. Up here. Switch. All right, we have our pulmonary gas exchange. This is up in the lungs. Tissue gas exchange, that's what's happening in the tissue. So you'll see, right, as the systemic blood is returning back to the lungs, we got a 45 millimeters of mercury, all right, partial pressure of carbon dioxide. You breathe that out, and then it drops down to 40 millimeters of mercury, and then it circulates back to your systemic cells here at 40 millimeters of mercury, which is going to promote, all right, the diffusion of carbon dioxide into the blood from your tissues there. Now, one of the things, and again, it's a little bit easier to go over some of these concepts here, had I not expected you guys to watch some of the material on the videos here. But one of the things I do want to point out to you is when you breathe in, and if, for those of you that have watched the videos, when you exchange oxygen across the respiratory membrane in the lungs, right, you can see that the partial pressure of oxygen when it's coming to the lungs before gas exchange occurs is 40 millimeters of mercury. After oxygen diffuses into the pulmonary capillaries, it gets up to 104. But notice when it gets to the systemic cells here for tissue gas exchange, it drops down to 100 millimeters of mercury. So we're seeing a slight drop there. It's not huge, but it's slight. And I feel like if we have time, we'll talk about it a little bit more in lab. But what we're going to see is we're going to see some deoxygenated blood that is going to enter into the bronchial veins from some of the venous blood that actually supplies our lungs as an organ. So there's a slight mixture there, right? So usually by the time that the blood gets into the heart, right, and leaves the heart, it's usually around 100 millimeters of mercury. We're just seeing a slight mixture of deoxygenated blood with oxygenated blood. In case most people don't even ask me, why does this number drop from 104 to 100? But in case for those of you that were curious, now you know. We're getting some slight mixing of deoxygenated blood with primarily the oxygenated blood there. All right, let's discuss oxygen transport because we're going to be talking quite a bit about hemoglobin, right? So, and you all know the purpose of hemoglobin is to transport our respiratory gases, primarily, right, oxygen there. All right, so one of the things you want to understand, and again, I'm relying on you watching those previous videos, I know I might say that a lot tonight, all right, is the solubility coefficient of oxygen. And that just means how well can oxygen dissolve into a solution, okay? We all, if you have a soda in front of you, which I don't see anybody, right on, all right? But if you're drinking carbonated beverages, carbonated water, carbonated Coke, Pepsi, whatever, right? They're using carbon dioxide and they're forcing, they're moving that gas and putting it into water, okay? And so some gases can dissolve into a fluid much easier than others. Carbon dioxide is one of those, all right? Oxygen, not so much. So here's our scenario. Oxygen can't dissolve into our blood plasma very well. So therefore, it has what we call a low solubility coefficient. Just tells us that, you know, oxygen is not that good. So, all right, if we can't dissolve it into the plasma, that means we need something to pick it up to transport it around the blood. Well, guess what? Here comes our hero to the rescue, hemoglobin. Okay? Hemoglobin is that protein, that plasma protein that is going to transport oxygen. Pretty much 98% of oxygen that's traveling in your blood is going to be stuck onto the hemoglobin. The remaining amount is going, some will dissolve into our plasma, okay? But the majority of it, 98% is going to be bound to hemoglobin. So when oxygen is bound to hemoglobin, we call it oxyhemoglobin, and we write it like this, HbO2, right? If there is not going to be oxygen bound to hemoglobin, we call it deoxyhemoglobin, and we write it like this, HHB. Okay, so if you see that, if you're reading some literature, right, just know that if you see O2, which is oxygen, right, then you know, okay, that is going to be oxygenated or oxyhemoglobin. So that means that there's oxygen bound onto that hemoglobin. Do y'all remember how many molecules of, all right, good. I didn't have to finish the sentence. Yes, that's right. 4 oxygen molecules can bind to 1 hemoglobin molecule. Okay, it's worth noting that, right? Because you have millions, if not actually billions of hemoglobin molecules in circulation. So a lot is floating around out there. Okay, so first clinical view, measuring blood oxygen levels with the pulse oximeter. I do this all the time. Okay, so you put that, I'm sure that some of you may do it to folks, and some of you have had it done to you when you've gone in for a physical. They clip this thing onto your finger, and it will usually give you your oxygen saturation rate and your pulse rates. All right. And so I use it for the pulse part, but I always look at the oxygen saturation rate. And so this helps. Right. So this is going to tell us how much essentially oxygen is going to be floating at a given time in your blood. Okay. So it is our oxygen saturation. And so basically it takes these two values, oxygen and oxyhemoglobin and deoxyhemoglobin. All right, we set it up as a ratio, and normal readings are anything above 95%. So I don't know if any of you heard during COVID, when all the mask wearing was going on, people were saying if they were wearing masks that it wasn't allowing them enough oxygen to get to their blood, and so they weren't. So I ran my own little experiment. I walked from the parking lot when we used to have this class in building 120 with my mask on, and I brought my pulse oximeter with me, all right? And I measured it going up 3 flights of stairs. I never take the elevator, very rarely. And I walked up 3 flights of stairs, not strenuous, but enough. Didn't change it a bit, all right? While wearing the mask. So I just want to say, all right, so all that stuff that y'all may have heard, you heard it from me, that was not true, all right? Okay, so oxygen, easy. 98% of it jumps onto the hemoglobin, gets transported around through the blood, right? Carbon dioxide, little different. Carbon dioxide has 3 ways that we're going to transport it. Most of what we're going to see for our carbon dioxide is going to be transported in your blood by this molecule called bicarbonate. Bicarbonate is one of our buffers that you may have first learned about in chapter 2. More on that, okay, later. Then another way that we're going to see it is it dissolving into the blood plasma. Not a lot, only about 7%. And then the third is it can actually attach itself onto hemoglobin, but it can't attach onto the iron. Okay, iron is reserved only for oxygen. Okay, I'm almost positive there's a test question in there somewhere. Okay, so oxygen binds to the iron, whereas carbon dioxide is going to bind onto the globin portion, right, which is the amino group there, or amine group. That's a nitrogen containing component there. So those are the 3 ways that carbon dioxide travels in the blood, either dissolved in the plasma, attaches onto the hemoglobin molecule, onto the amine group there, or it is going to be converted into bicarbonate, which then will dissolve into your blood plasma. So we're going to kind of discuss how we're going to create bicarbonate, right? That buffer that we're going to discuss. Okay. So here's what happens. And I've got a nice picture, so I'm going to come back and forth here. So I'm going to just finish that slide, then we're going to come and look at this picture here so you can see the nice chemical equation here. All right. So essentially what's going to happen is carbon dioxide is going to move into your red blood cells, where we have the name of this enzyme. It's called carbonic anhydrase. And so it is essentially going to cause carbon dioxide and oxygen, okay, to interact with one another. And eventually, okay, it's going to form the bicarbonate molecule and a hydrogen ion, H+. Right? And as a result of this, we're going to see, all right, another molecule called chloride, okay, Cl, the negative sign there. We're going to see, all right, that chloride is going to move, all right, depending on which way we're swinging this equation, either from the plasma into the red blood cell or from the red blood cell into the plasma. I'll show you this in a moment here. Okay, so that's how we're going to transport it throughout the blood. So carbon dioxide gets kicked out of the tissue cell, booted into the blood, and then it's going to enter into a red blood cell, not bind with the hemoglobin, but instead of binding with the hemoglobin, it is actually going to hook up with water with the help of carbonic anhydrase, and then it's going to form, okay, bicarbonate ion and hydrogen, or the bicarbonate molecule and a hydrogen ion. And then when that carbon dioxide circulates up to the pulmonary capillaries, then we're going to swap it. We're going to reverse that whole process. Right? So I'll show you through a picture and it'll make sense. So anyways, and I'll show you what this whole chloride shift is, because we got to trade things. Because guess what? A hydrogen ion is what type of molecule? It's an ion. So is it positive or negative? The hydrogen? Yeah. Okay. So yeah. All right. Let me show you. You guys are good. Okay. So let's start off here with what's going on in our tissue capillaries. So let's just look at the equation here first. Okay. So you'll see step one, carbon dioxide leaves the tissue cells. Good on that? Goes into your blood plasma. It then diffuses into the red blood cell where carbonic anhydrase is waiting for it. Plenty of water, okay? So carbon dioxide and water combined for a short period of time to form this weak acid. Do y'all remember the name of that weak acid? We saw it before. It was chapter 20. Carbonic acid, okay? Carbonic acid, right? So weak acid. So carbonic acid will then dissociate into a hydrogen ion, right, which is going to hang out on the hemoglobin molecule, and then our bicarbonate molecule. So bicarbonate is negatively charged, so it's going to diffuse out of the cell. So we've got to swap a negative for a negative. We want to keep everything equal. So when we swap out the bicarbonates into our blood plasma, then it's like a tag team. If you've ever seen a tag team wrestling match, you tag one person in, the other guy leaves. All right, that's what's going to happen here. As bicarbonate leaves the cell, chloride enters into the cell. That's what we refer to as the chloride shift. All right, so then this whole thing circulates back to the lungs. All right, so we get back into the lungs here, the pulmonary capillaries, then bicarbonate moves back into the red blood cell. It reattaches with the hydrogen ion that pops off of, all right, the hemoglobin molecule for a brief period of time. Okay, those two molecules are reunited with the help of carbonic anhydrase. It plays both sides of this equation. Carbonic anhydrase quickly forms the carbonic acid molecule. And then carbonic acid then dissociates into carbon dioxide and water. And then carbon dioxide shifts out of the red blood cell, moves into the alveolus. Why? Why does this gas go from the blood into your lung space? Nailed it. Partial pressure. Yep, the partial pressure of carbon dioxide is higher here in the pulmonary capillary than it is in the lungs. And so it goes from high to low. moves into the lungs, you breathe it out. And that's how we move, all right, about 70% of your carbon dioxide through your cells, through your systemic circulation there. All right, take your time. This is figure 2331. So if you're not quite sure, okay, I didn't go over the actual literature on the side there. You can go ahead and read through that. I just kind of went through the finer points there. But just understand that the enzyme that you need is carbonic anhydrase. It has the ability to shift that equation, all right, in either direction, depending on what location you're in. If you're in the cells, okay, and we want to have carbon dioxide move, all right, if we want to have the carbon dioxide move into the cell so we can move it back to the lungs, carbonic anhydrase is going to form the bicarbonate molecule. And we'll talk a little bit more about bicarbonate because when we get into chapter 24, we're going to talk a little bit about acid-base balance and buffering. Because remember, we want to keep our pH levels, right, normal, right? 7.35 to 7.45. Right? And so one of the ways that we can do that is with the help of bicarbonate. Because look, how do we make bicarbonate? Right? It involves the formation of carbonic acid, but look what we'll see. You get, as a result, when carbonic acid dissociates and it yields bicarbonate, it also yields a proton ion, right? A hydrogen ion. And what did we say about a solution that has a lot of hydrogen ions in that solution? It's acidic. That's right. It drops our pH. We don't want that. So we're going to learn about a little bit on how we are able to buffer that, right, in chapter 24. Okay. So here you can see hemoglobin is going to transport oxygen. It's going to transport carbon dioxide, right? Remember, about 23% of carbon dioxide is bound onto the globin portion of that protein molecule. And then remember that hydrogen ion from this picture here? That hydrogen ion also jumps onto the hemoglobin molecule, onto the globin portion of it. So three things are going to be bound onto our hemoglobin here. Now understand these three things: oxygen, carbon dioxide, and hydrogen. When they attach onto the hemoglobin and when they leave the hemoglobin, this is important, they are going to cause a shape change in the molecule. Okay, they're going to change the shape of this molecule. And depending on the configuration or the shape of that molecule, it might make things easier to bind onto it, or it can make things harder to bind onto it. And we're going to discuss some of those things there, right? So that's the big thing here. So those shape changes are going to influence, right, how well hemoglobin can bind to things, and then how well it can release those things once they've bound. Because we don't want to have, think about it, do we want to have a really tight, strong bond between hemoglobin and oxygen, for example? No. You want it to be able to pop off when it gets to the lungs because that blood is moving fast. And you got to get, all right, oxygen, all right, from the lungs onto the red blood, onto the hemoglobin, then get it to the cells. And we want it to pop off in the cells and diffuse right into the tissue there. All right, so we'll discuss this. All right, this brings me to, and I'm going to slow things down here a little bit. All right, and talk about, all right, this binding curve or this oxygen binding curve. All right. We said hemoglobin, one molecule can bind 4 oxygen molecules, and they attach to the iron portion, right? Good. Okay. So how much oxygen that is attached onto this hemoglobin molecule, we call that saturation. Right? How much is bound onto that is going to affect its ability to bind more oxygen or release oxygen. And I'll explain what that means there, all right? So as the saturation goes up, this is one of those ratios, not an inverse ratio, right? It's going to be a proportional ratio. You increase one, you increase the other, okay? So as more oxygen binds onto the hydrogen or to the hemoglobin, we're going to increase that partial pressure of the oxygen. Is there a way I can make this go away? It's annoying me. There we go. Okay. So that brings us to this concept called the cooperative binding effect. As more oxygen binds onto the hemoglobin molecule, it's going to change its shape. And here's the nice thing, because it always seems like life is hard. Well, this is one of the situations where it gets easier, right? So just like the longer you work at a job, supposedly it gets easier. So the more oxygen that binds onto hemoglobin, right, the easier it is for the next oxygen to bind onto it. So it only encourages more oxygen to bind on. So say you have a deoxyhemoglobin molecule come floating along. No oxygen is bound to it. The first one that binds onto it makes it easier for the second one to bind onto it, which makes it easier for the third and the fourth. So I'm going to show you this little graph here, and you'll see, right, it has this S-shaped curvature configuration where it looks like this. So basically, that's what you're seeing up here on the screen. So you'll see there's the partial pressure of oxygen, right, and then the percent or the oxygen saturation. So you'll notice, okay, when there's no oxygen bound on there, then when we get one oxygen molecule to bind onto it, all right, it pushes up the partial pressure a little bit. But you'll notice we don't have to go very much higher in partial pressure to get more oxygen to bind onto that. Right. So you'll notice when we get into right around, oh, I can't see from my angle. So when you get to about D here, which is about 98%, you're only at 80 millimeters of mercury, okay? The only way to get 100% of oxygen to bind onto hemoglobin is to pretty much be breathing in 100% oxygen, right? We have to increase that partial pressure significantly, right? Like in a barometric chamber sort of thing. And that's actually, it's in one of the previous videos there. When you watch it, we talk about that. When we talk about the partial pressure of oxygen and oxygen solubility, the bends, y'all familiar with, you ever heard of the bends, you know, with divers and all that? ER. On what? Is that a documentary? What is that show? Sounds like something from North Carolina. Is it North Carolina? Okay. All right. Outer Banks. It's filmed in Charleston? Oh. Oh, like Southern Charm. Yeah. I watched Southern Charm. Don't judge me. Don't judge me. Wait, you don't know Southern Charm? Has anyone here at least heard of Southern Charm? So this is what we're seeing here. My basic point that I want you to understand is, all right, as we increase the partial pressure, we can much more easier, all right, bind or increase our oxygen saturation for our hemoglobin here, which only makes sense, all right, because if you're exercising, you're going to start, all right, to increase your breathing rates. You're going to increase your force of breathing and increase the amount of oxygen that you're bringing in, right? You can take your tidal volume from maybe 500 to 700, 800 milliliters, right, as you're breathing in. So we're going to be able to increase that partial pressure, thereby increasing, right, the amount of oxygen that is getting saturated or attaching itself to your hemoglobin there. Okay, so that brings me to the next part here, that saturation curve here. So again, like I said, small increases, all right, of partial pressure will create large increases in saturation there. Okay, boom. So what does this mean for our class? Well, if you're going to travel to areas that for different elevations, like for example, when you're at sea level, you're at pretty high oxygen saturation, but when you start to get to higher elevations, well, I guess there are some mountains around here. They're around 5,000. I think Black Mountain, Grandfather Mountain, all those areas there. All right, when you get up to about 5,000 feet of elevation, your partial pressure is 81. But not to worry, because according to our graph, your oxygen saturation is 95. So if we're at around 81 here, you'll notice, I hate when that happens. You'll notice how we're close to 95, 98%. And that's at just a partial pressure of 80. Now, if you go up in elevation to, I think the example is 17,000, all right, feet, your partial pressure is 40 millimeters, but still 3/4 or 75% of your hemoglobin can still be saturated. That's pretty good. That means roughly 2 to 3 molecules of oxygen can be attached to hemoglobin at any one time there. All right. So one of the things that we will do, which I used to be big into ice climbing, and my goal was, before I got married, was to climb Mount Everest, and then I was told I was not allowed to once I got married. All right, but if I won the lottery, I would still do that. All right, but point being is, what you're going to see here is one of the things with altitude sickness, because you have a low oxygen saturation, because of all the effects that are going to occur when you have altitude sickness, we're not seeing a very high partial pressure of oxygen, so we can't saturate a lot of the tissues. You can get cerebral edema, which is what? What's cerebral mean? Brain. Edema is swelling. Yeah. Okay. So that's one of the things that you can be concerned about. You start to see patients with cerebral edema, then they could get obviously nausea, vomiting, really bad headaches, weakness, delirium. One guy in 1996, he was so delirious from altitude sickness that he walked off the edge of the mountain. It's a good book, Into Thin Air, if you've ever read it. Have you read it, Christian? Yeah, by John Krakauer. Really good book. He also did Into the Wild, I believe. Anyways, it's a fascinating story. It's about how a disaster occurred on Mount Everest in 96, where I can't remember if it was 10 people died. It was bad. It was bad. A storm came out of nowhere. But anyways, this guy was wandering around the mountain. And the crazy part was he came to, I think, John's tent. And he said, I can't, he thought it was his tent. And John's like, no, your tent's right over there. And the guy walks right back out into the blizzard and walks off the mountain. Yeah, it's sad. It's sad. But anyways, so point being is, with altitude sickness here, if we decrease that partial pressure of oxygen, we're going to see, obviously, at those high elevations, 26,000 feet, which I think is that the death zone? I know, I think it's either 26 or above 20. Is it above 21? Okay, they call it, literally, this is no lie. When you get to this altitude, you are technically starting to die. All right. I know. I did. I did. I did. Okay. So here we go. Let's talk about what happens. All right. About we just talked about how we get oxygen onto hemoglobin. How about when we get it off the hemoglobin? All right. So keep in mind, very rarely does all the oxygen ever come off of hemoglobin. Right. So you'll always have a little bit on there, because really you're always going to have some sort of partial pressure of oxygen in your body, even when it's at its lowest. All right. When we get to the lungs and it's around 40 millimeters of mercury, look what we're dealing with here. 40 millimeters of mercury, you shoot right up, right? It's about 75% saturated. So keep that in mind. The only way to really not have any hemoglobin with any oxygen on it is to have no oxygen pressure involved. And we're always going to have that. So keep in mind, at the cells too, we'll see, and just this is going on with us right now, right? When that hemoglobin is leaving your cells and it's dropped off some oxygen, it is 75% still saturated there, right? So you're only releasing a small amount, which is good in the sense that, say you start to exercise strenuously, then that hemoglobin still has some like oxygen reserves, so you can then give off that oxygen in case of increasing metabolism. So we refer to that as the oxygen reserve there, the remaining amount of oxygen bound to, right, the hemoglobin there as it's circulating through your body. So like I said, when you start to exercise hardcore, we can still drop off oxygen to those metabolically active tissues, right, to the point where even at real low partial pressure of oxygen, you'll still have, all right, close to 25, 40% of the oxygen, or excuse me, hemoglobin having oxygen attached to it. Yes, ma'am. Usually, right. So this goes back to that supply and demand situation. So those tissues there, all right, in your brain are not getting enough oxygen. So that could be a couple reasons. Blood flow is insufficient for whatever reason, and or the amount of blood that is saturated with oxygen is low. And so that, of course, will cause decreased oxygen being transported from the blood into those cells. And so they're not making enough ATP or whatever they need the oxygen for primarily. And you will start to see a buildup of like lactic acids, that sort of thing. And then you start to mess with pH levels. Then you can get, I mean, I could go on and on, all right? But usually when you're talking about lightheadedness, it's just your oxygen, you're not getting enough oxygen to the tissues there in the brain. Okay, so what are some of the other things that are going to affect, right, oxygen release from hemoglobin? One is temperature. Here's the thing, and I like this because it just makes sense. When you exercise, do you get cold? No, you heat up. Okay, your body temperature increases, blood circulation increases, tissues become more metabolically active, you're burning more calories. Those are what we call exothermic reactions, which means that heat is one of the byproducts for those reactions. And so that increases body temperature. And so increase in body temperature allows for oxygen to pop off of hemoglobin easier. I can't talk tonight, right? Pardon? I don't think, is my mouth drooping? All right. No, okay. So yeah, so increase in body temperatures, we're gonna see that binding effect for oxygen on hemoglobin decrease so it can pop off the molecule and go into the tissues, all right, with less difficulty, okay? If we increase, all right, the amount of hydrogen ions binding to hemoglobin, okay? Hydrogen ions, again, we just saw one of the ways that we can produce hydrogen ions, right? With increased carbon dioxide levels in your blood, you'll increase the hydrogen ion concentration. And some of you are thinking, well, how? Right here, y'all. This whole process, this. The more of this that you have in your blood, the more of this you'll get made, okay? Through this process. Okay, because we're going to be transporting it. So keep that in mind, that correlation. So if you have more carbon dioxide, what do you think you are doing if you have more carbon dioxide production? What's happening? The cells are more active, right? Their metabolism is increasing because what is carbon dioxide? It's the respiratory waste gas. Okay, it's like the exhaust in your car. Okay, so that's what the cells are going to be kicking off because they're becoming more metabolically active. So when we're transporting that, all right, carbon dioxide, if we have more carbon dioxide to transport, that means we have more hydrogen ions that are binding to hemoglobin. Guess what that's going to do for oxygen? It is going to make oxygen want to pop off of hemoglobin that much more. It has, right? And so when that occurs, where's that oxygen going to go? Into the metabolically active tissues there. So we call this the Bohr effect. That will also, we'll see. So essentially what you could say is if you start to see a decrease in pH, you will start to see the Bohr effect in action. Okay, so if our blood pH goes from 7.35 to 7.28, all right, or 7.2, we're starting to become more acidic, right? That's because we have more hydrogen ions in our solution, in our blood, right? Even though it's bound onto the globin portion of the red blood cell, right? And so as a result, that's going to kick oxygen off that's already bound onto those hemoglobin molecules so it can come out of the red blood cell and into the tissues there. So keep that in mind. That is called the Bohr effect. All right, then we've got this guy here, 2,3-BPG. and I used to remember, I can't recall the name of that specific molecule here, all right? But this is a molecule, all right, that is present in your red blood cells. And so if we see an increase in the presence of 2,3-BPG, we will see it push more oxygen, again, off of the hemoglobin molecule into your blood cells here. And so you'll see these hormones here that are going to increase the production of that. All right, what about carbon dioxide? What is that going to do? Same thing, y'all. Increase carbon dioxide levels, get rid of oxygen off the hemoglobin. All right, so this whole thing, right, as oxygen either comes onto the carbon dioxide or when it's released off the carbon dioxide, we see a shape change to that molecule there. And as it changes its shape, all right, we can now increase the amount of carbon dioxide that is going to bind. So we're replacing oxygen. This is called the Haldane effect. We're going to replace that oxygen, right, once it gets kicked off because we have more carbon dioxide. Think about it. It's all about balance, y'all. I don't know how many times I could say this. Hemoglobin, not hemoglobin. I'm having a bad day today, and it started off so good. This is what happens when you don't get enough sleep, right? When you're sleep deprived. Hemostasis, right? That balance, that healthy operating system, right? We want to maintain certain amounts of carbon dioxide. You want to maintain certain amounts of oxygen. If carbon dioxide increases, we have to rid it from our body to make sure that we keep the levels, especially the pH levels in your blood, right, within that 7.35 to 7.45. So if we're pushing oxygen off of the hemoglobin molecule, we can replace it with carbon dioxide so we can hurry up and circulate it back to the lungs so you can exhale it off, decreasing carbon dioxide levels, increasing your pH from a low pH back to the normal range, right? Shooting for 7.4. Right, that's what we're trying to do. The Haldane effect is an example of that. So here you can see a couple examples here in the lungs here, that same process, right? As we are transporting carbon dioxide, right, in our red blood cells as bicarbonate there, okay, in the blood plasma, it can actually attach onto the globin molecule there, and then a small percent, about 7% is diffused into, not diffused, excuse me, is dissolved into the blood plasma. All right, this one here is showing you, there's 2,3-BPG. And again, we don't really cover this, but this is one of the intermediate molecules that is produced during glycolysis. Right, we would talk about that in chapter 27, okay, but we won't be discussing that, but that's one of the molecules that we'll see, all right, during glycolysis. And so again, when are you going to be utilizing glycolysis, right? During the metabolism of glucose. When does that happen? When you need fuel, right, to create ATP. So more metabolically active tissues are going to be engaging in glycolysis, which is going to be producing more intermediates here. One of those intermediates is 2,3-BPG. Okay. Shifts to the curve. So in our, well, let me go to this slide here real fast. Here you can see when we're looking at the oxygen saturation curve here, that's that blue line there, right? Normal body temperature is the example here. But we can either shift this curve to the right for whatever reason, depending on what specific occurrence is happening, or we can shift it over here to the left. I'm going to run through some of those, okay? So when we talk about shifts to the saturation curves, right? If we get a right shift, right, that means it's going to be easier for oxygen to disassociate or pop off of hemoglobin. So things like increased temperature, all right, increased hydrogen ion concentration because we have an increase in carbon dioxide. So anything that causes that curve to shift to the right means hemoglobin is going to want to hold on to oxygen less. So essentially, we're going to decrease the oxygen affinity for hemoglobin. Oxygen will pop off hemoglobin that much easier. If we shift it to the left, we're going to increase the affinity for oxygen, right, to hemoglobin, which means it's going to be more difficult for oxygen to pop off of hemoglobin here. So decrease in temperature when you're cold, okay, right? Decrease in hydrogen ions, right? If you're at that more basic or alkaline range of your normal pH there, you will see that it's going to hold on to oxygen a little bit better. So that's what these 3 or 5 examples are showing you here. It's not what I wanted. Right, that's what we're going to see here. All right, so the top one here is going to be when we have, all right, our oxygen levels here, just regular chilling out, right? So partial pressure of oxygen is 95 millimeters of mercury, right? You'll notice if you look back on our curve here, about 75% of that hemoglobin is saturated. And then our partial pressure in our tissues is much lower. So we're going to drop off, right? Anywhere between 30 to 25% of that oxygen is going to pop off right into the tissues normally. Now, when you start to exercise, you're going to see our body temperature increasing, right, up to 41, 42, 43 degrees Celsius there. And so we get what's called that right shift. And so you'll notice, right, at our partial pressure here, we'll get a lower saturation of oxygen because it's popping off easier. And then conversely, in colder temperatures, right, at 40 millimeters of mercury, right, it takes, right, a lot more for oxygen to pop off because the hemoglobin is going to hold on to it a little bit longer. We move down here, here's the Bohr effect. When we when we decrease our pH or increase our hydrogen ion, all right, saturation, okay, you'll notice we get that right shift. Oxygen pops off more. When we decrease or increase our pH, it likes to stay on a little bit longer. It has a higher affinity. And then here, during metabolic activity here, when we start to increase the amount of 2,3-BPG, that intermediate in glycolysis here, right, again, we'll see a shift in which it pops off. And then our carbon dioxide binding, same thing. We'll see an increase in carbon dioxide, obviously in more metabolically active tissues there. And that is going to cause oxygen to pop off of carbon dioxide. Golly, slow down. It's going to cause it to pop off of hemoglobin, causing that conformational state change, changes the shape of hemoglobin, which encourages carbon dioxide to bind onto it and not as much oxygen there, so the oxygen can go into the tissues. All right, y'all are familiar with carbon monoxide. What's one of the big signs of carbon monoxide poisoning? Yeah, very red lips. They describe it as cherry red lips. So you can tell somebody has carbon dioxide poisoning because their blood, right, will be bright red. All right, and that's because carbon monoxide has a greater affinity for binding to hemoglobin than oxygen does. Okay. So oxygen, up until this point, we thought, well, that has top billing for hemoglobin. Not with carbon dioxide, okay? Carbon dioxide has a greater affinity to binding onto hemoglobin than oxygen does. So, does anyone know, is it up there? It is up there. I was gonna say, how we treat carbon monoxide poisoning is you put somebody in a hyperbaric chamber and just blast them with 100% oxygen, because that high partial pressure of oxygen will force the carbon monoxide molecule off of the hemoglobin molecule so oxygen can get on there. So they just have to sit in there for a while. Okay. Yeah, don't cook in your tents and don't fall asleep in your car while you're warming it up in the garage in the wintertime. Yeah, always put the garage door open.
Like no carbon monoxide. Like that's what part of this.
So let's get into hyperventilation and hypoventilation, especially how that affects your heart. So y'all are familiar with the terms, okay? Hyperventilation, okay? Increased breathing rate and the depth. So you'll take faster breaths, but deeper breaths, right? And so obviously hypoventilation is going to be the opposite. So several things can cause hyperventilation. Emotional disparages, like anxiety, okay, high altitudes, right? Or if you've ever seen divers, okay, especially professional divers, the ones that go without the tanks or whatnot, one of the first things that they do before they're ready to descend is that they'll force themselves to breathe as fast as they can and as deep as they can. Right? Because partly what they're doing is trying to force off as much carbon dioxide from their body and trying to bring in as much oxygen to saturate their blood and their hemoglobin, right, before they can descend. All right. So that's essentially what we're going to see. We're going to see, all right, we're going to see an increase in our oxygen partial pressure as we breathe off as much carbon dioxide as we possibly can. All right. So we're going to try to get our oxygen saturation rate as close to 100 as possible. I had a patient, and again, I don't necessarily think that the pulse oximeter was 100% correct, that told me that they had 100% saturation, right? Is that possible? Maybe for a brief moment there, but on average, we're going to see normally it's going to be around 98%. Not saying that it's not possible, right, for people to have a higher than 98% blood saturation or oxygen saturation. Okay. So when we see a big loss of carbon dioxide in the blood, mind you, in the blood, okay, we call that hypcapnia. All right, just know that term. Okay, a lot of carbon dioxide loss from the blood, hypcapnia. Hyperventilation, okay. Think about what we're doing. Deeper breaths. Increased breathing rate, blowing off as much carbon dioxide as possible, right? This will cause vasoconstriction. This goes back to when we were discussing in the circulatory system, the local effects of certain molecules on your blood flow, okay? If you remember from chapter 20, right? And one of those was the levels of carbon dioxide and the levels of oxygen. So low blood carbon dioxide is going to cause vasoconstriction. And as you know, that vasoconstriction, right, is going to increase the resistance and decrease blood flow. So therefore, we're going to see less oxygen, right, being delivered to the brain. So your brain is going to want to respond, okay, by increasing blood flow there, okay? So in this case here, and we haven't really talked about, right, the buffers here, right? But what we can see is, right, we're going to see an increase in blood hydrogen ion concentration. Because why? Well, how do we get the hydrogen? Well, carbon dioxide is going to is going to relate with that. So when the buffers in your blood, and again, I apologize because of the hurricane, we aren't going to be able to talk a lot about the buffering system this semester, right? But when the buffers, because that's the job of the buffer. The buffer is supposed to prevent changes in your blood pH. When they are unable to, okay, then we're going to have to go through more serious measures. But when they're unable to, you're going to result in what we call respiratory alkalosis, right? And that respiratory alkalosis, we get a decrease of that blood hydrogen ion concentration. As you know, if a solution has low hydrogen ion concentration, it is a what kind of solution? Alkaline or basic, right? So we're going to see this respiratory alkalosis here. And so because of that, we decrease the blood flow to your brain with that vasoconstriction. Don't these symptoms make sense? Dizziness, lightheadedness, fainting, right? In some cases, you can get numbness and tingling because it's going to affect, right, blood flow to the neurons there. God forbid, bless you, it gets worse, right, with cramping and even tetany, that sustained muscle contraction there. And then if this continues on and we're not able to compensate in that respiratory alkalosis, then you can result in coma, and then, God forbid, okay, death. All right, what's the other part of that? The other side of the coin is hypoventilation, all right, when we decrease, all right, your breathing rate there, or you decrease the depth of your breathing. Numerous causes there. Let me take your pick. Airway obstruction. Why brainstem injury? How can that cause decreased ventilation? Yeah, you've got your breathing centers there. Okay, breathing centers, your circulatory centers, your heart rate centers. I mean, you take your pick. Right, all sorts of things can happen. All right, so if we decrease our rate of breathing and the depth of breathing, what's going to happen? Oxygen is going to decrease. Carbon dioxide levels are going to increase because we can't breathe it off. Right, so you're going to see low blood oxygen levels. We call that hypoxemia. Right, emia is blood. All right, and then this, God forbid, right, if it translates into the tissues, then you have hypoxia. And eventually you can lead to tissue necrosis and tissue death, right? And then when we see an increase in the partial pressure of carbon dioxide, right, we've got hypercapnia. Know these terms, okay? Know these terms. It'll help you. Yes, sir.
P means partial pressure.
Yep, P means partial pressure. Okay, so as a result, you're not able to get an exchange of the respiratory gases across the respiratory membrane. Right? Therefore, we're going to have less oxygen in circulation. Less oxygen will be delivered to your tissues there. And so as a result, the tissues still are going to have their demand. They're going to still be metabolically active. And so they're going to still be kicking out, all right, carbon dioxide. So your carbon dioxide levels will start to increase and accumulate. You can't breathe them off because your breathing rate is less and you're breathing more shallow. So the more carbon dioxide that you create, the more hydrogen ions you create. And more hydrogen ions in your blood is going to lead to a lower blood pH. Therefore, if the buffers can't accommodate for that, now have respiratory acidosis. And then there's a whole list of symptoms there. What's lethargy? Yeah, you get tired, okay? Sleepiness, headache, polycythemia, your blood starts to thicken, okay? What does cyanotic mean? Low tissue oxygenation, yeah, okay? So you'll turn blue, your lips will turn blue, not your whole body, all right? What was the name of the girl in Willy Wonka that turned blue? Violet, thank you, yes. Yeah, I like Augustus Gloop. All right. No, stop. Don't do that. All right. So anyways, you can eventually end up in death. Okay. So a whole host of things that can happen. So what about with exercise? And this is something that can apply to any of us because for some of us, as I'm getting older, you know, my heart rate increases, my breathing rate increases when I go up a flight of stairs. And so I have to get used to that. And it's sad that I consider mowing my lawn exercise, but I do. All right. But I do. Okay. When I have a perfectly capable 14 and 17-year-old that can mow my lawn, but I still do it. Okay. So what happens here when we're talking about, all right, breathing and exercise? Remember, when you are exercising, your tissues are becoming more metabolically active. So this is where we go back to supply and demand. All right. So your respiratory system needs to acquiesce to the demands of, all right, those tissues that are going to be doing whatever function that they're doing during the exercise. The skeletal muscles, right? They're going to be, if you're running, okay, they have specific demands. And so we need to maintain, all right, an adequate breathing rate and a depth of breathing to make sure that we can get enough oxygen into your blood here. So the nice thing about it is when we're dealing with partial pressure of oxygen and partial pressure of carbon dioxide. This is important that you know this. those stay relatively constant. Okay. As you think about it, as your tissues are pulling more oxygen out of your blood and putting more carbon dioxide into your blood, your breathing increases to get rid of that increased carbon dioxide and to pull in that oxygen for those tissues into circulation. That's what we're talking about. Blood partial pressure of oxygen and blood partial pressure of carbon dioxide is going to remain fairly constant, okay? Because we want to keep supplying oxygen to those exercising tissues, and we want to keep getting rid of that carbon dioxide there, right? Because we've increased the production of ATP. Makes sense, right? The mitochondria are going to be pumping out more ATP because your muscle cells need more ATP. So you need more oxygen to make that ATP. So as those tissues become more metabolically active, what happens to your blood flow? Increases, right? I mean, we learned that back in chapter 20, right? Heart rate increases. Okay, remember blood flow and cardiac output are proportional to one another. If you increase your cardiac output, you're going to increase your blood flow. Why? Well, primarily because you're increasing your heart rate. Okay. And then you'll see some other things. We're going to reduce resistance so we can increase the blood flow. We're going to change the we're going to change the pressure gradients, all right, as things are moving throughout. So just kind of keep that in mind. These previous chapters that we've gone through, right, some of those concepts apply here. So you should start to be able to understand them a little bit, all right? So the deeper breathing is going to bring more oxygen into your blood, right? Well, we've increased our cardiac output, and cardiac output is proportional to blood flow here, right? And we learned earlier in this chapter, what were some of the things that affect, all right, your respiratory center? One was, we talked about the different receptors. Remember, we talked about the chemoreceptors, right? The baroreceptors. Well, we can't forget about the proprioceptors. Remember those receptors that are around your joints and the muscles of the joints, right? When those joints become more active because you're moving more, you're running, let's say, more signals are going to travel from those joints to your brain. And it's going to say, hey, the body's more active here. We're moving more. We need more oxygen there. So the proprioceptors are going to increase their signal output. So that will stimulate the respiratory center. Right? You're going to see the motor output from the cerebral cortex because you can actually, remember, breathing is still relatively voluntary. Okay, so if you want to, you can quicken your breathing rates, right, voluntarily doing it. And you can also increase the depth of your breathing rate, right, when you're exercising. And that's it. I know, everyone's like, yes, respiratory, over.